Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast series is to bring you short, educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment in the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job of caring for people living with dementia and connecting them and their care partners to the things they need. I'm here today with Dr. Sandeep Pagali, who's Associate Professor of Medicine at the Mayo Clinic in Rochester and the Medical Director of Inpatient Geriatrics. And really excited to talk about your presentation today for our webinar, going over tried and true, the new insights into behavioral management in dementia. So this is a topic that comes up over and over again. We kind of can never get enough because it's really hard to manage. So just want to say thank you for joining us and welcome.
Thank you so much, Dr. Chodos, for inviting me. I'm very excited to be here, as this is a topic that is very near and dear to my heart and very passionate about how we care for older adults, especially struggling with the behavioral and psychological symptoms of dementia. Over years in my clinical practice, I felt I was challenged myself. How do I manage this? How do I see this? So I believe this is a very important topic for us as we care for older adults with dementia. So thanks for the opportunity to be here with you today.
Oh my gosh, absolutely. Yeah, could not agree with you more. And just the impact it has on people's lives. And so great. I'm excited to talk about and kind of get around to what we can do better. But probably we need to start with, what are we talking about? So what do you want people to know when you're talking about these symptoms?
Thank you. That's a wonderful question. And I think it highlights the importance of the dementia and all the changes that occur with the progression of dementia itself. Patients or older adults with dementia, and usually there are some changes both in their behaviors and psychological symptoms that occur, which may go unnoticed if we do not have a specific lens towards detecting those symptoms promptly. There is a huge value in identifying them promptly because that avoids and eliminates a lot of frustration and unnecessary testing in the wrong direction for patients, families, healthcare system, and everyone involved in the care of these patients, right? As clinicians, having a good awareness of what these possible symptoms are is very important. And we hope that I think as we talk more about these symptoms, as clinicians, if we identify them promptly, that will help our patients and their caregivers equally as well.
So what are we identifying?
In terms of what scientific evidence thus far suggests is that the symptoms can vary on a spectrum basis. Not all patients will have to follow the same spectrum, or all patients will have the same symptoms. The myriad of symptoms can vary from mild depression or apathy in patients who have mild to moderate dementias, and sometimes just even if you're suspecting cognitive impairment, the manifestation of cognitive impairment can be an apathy or mood changes or depression. Literature has strongly suggested that these symptoms can be used as a red flag symptom to screen for cognition as well. So I think I would want to highlight the correlation and association between these two. So patients with dementia or at a high risk for dementia can have some mood changes. So keeping an eye open for any mood changes, specifically depression, apathy, are important. And as the spectrum or the progression of dementia occurs from mild to moderate to severe, more additional symptoms such as agitation, aggression, violence, or personality changes, new psychosis can all be manifestations. We have heard probably wandering behaviors or physical assaults that is completely out of their character. These are all specific behaviors that constitute the spectrum of behavioral and psychological symptoms of dementia. So not every person has to go through every single aspect of it, but any of these can start at any phase of their dementia journey. It can be in the mild dementia category or in the cognitive impairment without the dementia diagnosis itself, to all the way to severe dementia. But I believe, or at least being in the hospital practice, I do see very commonly that many patients with dementia do experience this, but it is also heavily underdiagnosed and under-identified.
Thank you. I really got the sense of like how common these symptoms are across all stages, but that how maybe some of these symptoms aren't things that we recognize and sort of like put in the category of behavioral and psychological symptoms of dementia because they're subtle or they're not calling out for attention per se, like the apathy that you mentioned or just some depressed mood. So how would you quantify or start to really get your hands around what symptoms the person's having and how serious they are?
Thanks again. This is a very wonderful and important question for us. I would start thinking about as identifying the problem itself and its correlation with memory problem is very important. What we don't want to do as clinicians is write it off saying that this is just dementia. Dementia with depression is equally important to identify that additional behavioral symptoms so that we can address and manage the depression promptly, even though the patient has dementia. And so we use the regular tools for depression. So we should continue to use the same screening tools to identify the specific symptoms that there is a concern for. Not all changes are routine changes because of dementia. Any change, even in a patient with memory problems, needs to be identified and treated or managed appropriately. So I think that is the first thing I would say if you're thinking about depression or agitation or psychosis or any other condition, we need to classify them or identify that this is a new symptom to start with. With that said, we would also use data points. And when I mean by data points, like if you're using the PHQ scale for identifying depression, we want to monitor the response of a treatment plan and continue to monitor the depression, and just don't say we started so and so medication and now we will not this is depression on dementia and just leave it be. We should continue to monitor the how much of the impact did the medication have on the depression itself, and we can use our standard scales. But as dementia progresses and there are a multitude of these symptoms, one of the common things that get used is called as agitation. And one of the things that we always see is like somebody is agitated, let's get them admitted into the hospital, or somebody is agitated, let's get a medication added in the nursing home, or family can't care, there are a lot of agitated behaviors at home, let's get something else added at home. In that situation, identifying those behaviors by having the caregivers or whoever is providing the information describe in detail those behaviors and use standard scales to help capture all the behaviors is very, very important. There are validated scales. A recent study looked at about 88 different scales that are available to quantify behavioral and psychological symptoms of dementia. And what these scales do is really like one, capture the frequency of the behaviors and the intensity of the behaviors. If you think about it, we can think about, is the depression? Yes, but is the depression mild, moderate, severe? Is it, if you think about a behavior that is more physical violence towards caregivers, is it a daily behavior? If it is happening, is it resulting in injuries? Is it redirectable, non-redirectable? Those are aspects that are very important from a care team perspective so that we can have an effective care plan that matches those assessments, right? So in that spirit, I would say there are validated tools such as some of the tools that I use are the Cohen-Mansfield Agitation Inventory. There is a neuropsychiatric inventory called the NPI. There is the dementia observation checklist, screening forms that people have used in the nursing homes. So depending on the care setting you're in and depending on the office practice or the pace of your practice, you want to adapt a tool that works best for you and capture the behaviors, both in terms of severity, frequency, and also helps this to see if your management plan is effective to tackle these behaviors. You can also use these scales as longitudinal assessments to see the progression of the symptoms as well as the impact of your treatment. So there are tools, and I think we as clinicians should start consider using these tools to effectively measure that can better help us effectively manage these symptoms as well.
Any quick pros and cons of these tools? Because I personally would love to implement and use these tools more, but um, is there one that's like better for outpatient or better in terms of just feasibility in a clinical, like a time wise?
What I would say is, I just like as everything goes in medicine, like one size doesn't fit all. Like that is the reason we have 88 different tools out in literature, because every practice might be slightly different, and it also depends on outpatient pace. How much time would you have? What versus if the patient is in the ED setting, what would be a right tool to capture in the ED when you're trying to get information from the care home? So a different tool is better in different settings. And I would say some tools have copyrighted information. So whenever you're trying to explore and review the literature, make sure you're aware of the copyright information if there is any fees associated with it. But there are tools that you can access for free, or if you're using it for clinical use, you can seek permission. And many times, many of these providers, they just give free licensure for you to use it. So definitely make sure you're checking those aspects. We do a lot of study as well, like in terms of research studies on patients with dementia related behaviors. I have personally used both Cohen-Mansfield agitation inventory in as part of my practice, as well as the neuropsychiatric inventory, the NPI forms, for assessment of the behaviors. Depending on the research study and what outcomes I'm specifically looking at, I have chosen one of these two tools. We have also seen some of the nursing homes and some studies that are published specifically using the DOS scale, which is the Dementia Observation Screening Form. And this is a longitudinal form across shifts and across weeks for a patient who's in a care home with memory, and especially it is a memory care facility. That is also a very helpful tool in those settings. So different tools available, and I think it's up to us to say like which one fits our practice better.
Thank you. Yeah, I'm looking at, I think I've seen the NPI before, and I'm looking at the Cohen-Mansfield agitation inventory, and it's very detailed. But I think, especially as you're saying, in scenarios where this is a really big part of the person's presentation and symptoms, that it can really help kind of like ground things, like what are the extent of this person's symptoms, and then if we're making any changes, how effective are we? Another thing you bring up that's really helpful is a lot of us are in the outpatient world. We're doing primary care. We're trying to do a better job caring for people living with dementia. How does the inpatient environment and behaviors there kind of translate into the outpatient environment? Or kind of like what are the things we should be looking for?
Thanks again. Again, you always bring up wonderful points that are important for our practice. And as I reflect on it, as a inpatient geriatrics hospitalist, when I see patients in the hospital environment with dementia and behaviors, many times I would try to dig through the electronic health records, trying to identify the bits and pieces of information across timelines, or asking for caregivers what was the most reliable information, and trying to synthesize all of that into one piece together into a snapshot for me at that time. The same way, I hope, or with that experience, what I have been starting to do is in my discharge summaries, I try to summarize all the behaviors that we have noticed as well as like managed during the hospital stay, and what has been effective and what has not worked. We try to kind of formulate a brief summary of all their behaviors, specifically even if it is for a delirious patient or if it is for a dementia patient. When there are behaviors, we kind of summarize this into a small paragraph and saying these were the behaviors we noticed. If we did again, as you just mentioned, the Cohen-Mansfield agitation inventory is not something that I would use every shift in the hospital. That is too tedious. It wouldn't be feasible from a practical standpoint, but that is something we would think about on a weekly basis. Many times, as you might have seen in the hospital notes, the line that patient is agitated gets pulled on forward every single day in the hospital practice, and that doesn't really reflect what has helped the patient, what has not helped the patient. So a thorough summary of what were the behaviors. And I can give you a brief example. I'll start off saying Mr. So-and-so had presented with these behaviors of wandering, agitation, physical aggression with an initial CMAI score of so-and-so. For example, we can say like 5s and 6s consistently across 6 domains. And then we would then say, we have tried these, or these are the things that we have attempted or tested and tried during our hospital course. These were not effective, but we found improvement in behaviors with these efforts of so and so non-pharmacological approaches. And these were the pharmacological approaches we tried. And this is where, after all of this, the CMAI currently stands at a score of 2 and 3s on these 2 or 3 domains. I think that would be a huge impact or a summary of how what has helped. And our hope is, instead of just purely relying on electronic health records and a discharge summary, we also take additional efforts to send a message to the PCP saying to communicate back and close the loop, because this is such a vulnerable population. There is caregivers and caregiver burden as well. Sometimes they might not be able to summarize all the information and changes that has happened during a hospital stay to the PCP. So we, as hospitalists or in the hospital system, we take additional effort to summarize this information and send it to the PCPs as well, summarizing. And said that we also would expect or hope or sometimes give some trajectories. If we ever had to use any medications, we also recommend if there is an opportunity for down titration of those medications. And I think that is something we always keep an open line of communication with our team. Though our healthcare system is siloed in our care setting practices, I think we as clinicians should channel or leverage communication to effectively transition cares of these patients who are really struggling with these symptoms.
Oh, yeah, absolutely. So what are your management strategies?
That's a wonderful question put in a small phrase. And I could say literature has proven beyond doubt that non-pharmacological approaches are always the first line of treatment. It has become the best practice guidelines across all societies as well. And I think that is one reason, because it is a best practice treatment, we would not find more active studies on that topic. We don't see probably 20 articles published on non-pharmacological approaches to manage dementia behaviors, is because it is best practices. Just like as we don't do studies on why we should use aspirin to treat acute coronary syndrome, right? So non-pharmacological approaches are your core treatment first line approaches to manage these behaviors. And many times what we have seen is de-escalation techniques, communication strategies, identifying the triggers for those behaviors, or managing the underlying behaviors. Many times it is that untreated depression in these patients that has really precipitated into an advanced major depressive disorder and psychosis kind of a situation as well. So trying to get to the bottom of it during the timeline, how this all started, how it is all managed, what were tried, what were tested, I think starts there. So non-pharmacological approaches is the key. Identifying the triggers, eliminating the triggers, while focusing on the patient in the center. We always take the age-friendly health system, the 4M approach, do a thorough medication reconciliation. Are there factors that are specifically worsening the cognition? Are there cholinergic medications that we have to be, the anticholinergic drugs that we have to be worried about to help to de-prescribe? That might be also helpful. So I still consider that as a non-pharmacological approach, because we are trying to take a pill away. And that is a crucial part as a clinician to think about twice in these patients specifically as well. Is like, is there something that we can trim it down? That said, the second thing I would mention is the pharmacological aspects, right? There are different medications out there, but the one thing that we do see a lot of studies, because this is something that has not been a solid, consistent approach that has been proven benefit across all patients. So studies have shown like antidepressant roles, like does antidepressant fix all behaviors? And I think as clinicians, we know like there is not one pill that can fix all the symptoms either. So I think that's what the studies reflect. Antidepressants do not change significantly the BPSD symptoms. But said that, I would say if depression is the main feature, trying an antidepressant is not a wrong thing in that situation. You want to address depression promptly as well. At the same time, if it is agitation or aggression, trying to identify the triggers. But coming to a pharmacological approach, there is no FDA approved medications to manage dementia related behavior safely. But said that, if we think about the antipsychotics, whenever patient safety or caregiver safety is at caution, then trying to use the lowest dose for the shortest duration is something we would consider. But again, they do have a lot of side effects, and this is an off-label use of the drug as well. On the third front, which I think I'm more excited about, is the new upcoming research on using neuromodulatory techniques such as transcranial magnetic stimulation or transcranial direct current stimulation or ECT as options. And these are like there is a lot of research happening across the country on these three domains, a lot of research publishing out, and this is outpatient stuff as well, right? So you don't need to be in a hospital to get these things done. It has supported both cognition. Some studies are focusing on the cognition improvement, while a lot of them are also studying the improvement in behavioral and psychological symptoms of dementia. Though none of them would reverse dementia, unfortunately, but I think it helps provide that quality of life by improving those behavioral and psychological symptoms as such overall. So I think that is something as the medical teams we are very excited to look forward, and hopefully will embrace our clinical practice here soon, and it becomes widely available for patients. That would be the TMS or the TDCS, the transcranial direct current stimulations, or the ECT. So I'm very excited about those potential opportunities as well from a treatment standpoint.
Have you seen these treatments in action?
We have seen, or literature has provided strong evidence for these treatments that they are effective. There are many systematic reviews as well as meta-analysis that have proven the benefit of TMS as well as TDCS and ECT for patients with behavioral and psychological symptoms of dementia. So like very recently, and all these studies are coming out in the last 1 to 2 years. There are numerous publications talking about TMS and cognition, TMS and behaviors, as well as ECT and behaviors. There is a significant role of TDCS in depression in patients with dementia as well. So I think a lot of studies, a lot of systematic reviews confirming the positive effect of these of the neuromodulatory techniques on BPSD symptoms in dementia.
That's just so interesting, and it's so cool to think about other options to treat these symptoms. When you're talking to patients and families or caregivers about these symptoms, how do you frame them, or how do you talk about them and the treatment goals? Like, what are we trying to manage? Because you referenced earlier, and we talk about this all the time, the non-pharmacological treatments, and a lot of that has to do with supporting the caregiving team for that person and getting them skills. And that sometimes I think feels really hard in primary care and outpatient care, like how we really support families and caregivers to do that. So I'm just wondering if you could share a little bit of your language or how you frame it for patients and caregivers, just so that we can take some of that home with us.
From a discussion standpoint, I believe like validating these symptoms to the caregivers is very important. Many times when there is advanced dementia, or even for patients with milder dementia, mentioning that these symptoms are a part of the disease process and it's not just them is important and helpful for them to know. That validation is important, and also helping them, removing the guilt from them, saying that it is not them doing this, but it is a part of this neurohumoral neurochemical imbalance that kind of really jives through the whole dementia progression. So I would start off mentioning, like calling out the behaviors, and mentioning that this is known to be the behavioral and psychological symptoms, and both that literature as well as my practical experience that I have seen this among other patients with dementia, and that they are not abnormal in this journey. So I think some reassurance and validation of their diagnosis symptoms is very important and helpful, and that's one of my first usually opening lines with the families or the patients themselves. Then the second part is like, what are the options or treatment modalities that are available? And when I mention about options, like this is what has been tested, or this is what has been tried, these are the best approaches, is like the safest is the non-pharmacological approaches, these are things to do. And when I usually enter that conversation and I say that this has worked, this has not worked, many times the families also open up and say like, yes, we have seen these things work for them in these phases, these things have not worked, these are what we have tried. I believe that is an important aspect, both from a history taking as well as building the collaboration or like the confidence of the patient and the family there together in this whole management care plan that we are going to develop next. The highlight thing I would mention that I to the families would be is like, I don't think this is solved by one action. The treatment plan should be a multifaceted or a multi-pronged approach to really handle all of this together. And I'll also mention that having an expectation. Let's say if this is where we are at, our expectations could be is like what can match to the quality of life, and see can we get there effectively and efficiently, or what are strategies we need to kind of achieve our goals. Having an education a little bit about the symptoms, progression of the disease, and the progression of the symptoms with the progression of the dementia, and then identifying depending on where they are at, if they are specifically in the mild or early dementia phases and they're struggling with apathy or depression, and we try approaches, I would kind of give them full reassurance. Hey, this is a goal. We have seen improvement in this degree and this much, and so I give them education about it and give them anticipatory guidance on what to expect next. On the flip side, if I'm looking at somebody who has very advanced dementia, significant agitated behaviors with which is involving harm to themselves or to the caregivers, and we are now at a phase where we have tried multiple things and hasn't worked much, then in those situations, I might really bring back my additional neuromodulatory techniques and say like, hey, these are still being under testing. This might just what we have seen or what literature has supported is this benefit. It has not been a clinical practice yet, but we can try these things. But this might be the improvement we can look for. But also like sometimes being transparent, right? I think that is very important. Like transparent in the sense like giving them that what we don't know, what the upcoming future is also something that both caregivers and patients are worried about. But if we bring our clinical experience from other patient journeys that we have seen and share it with them, that might be helpful for them. Many people have said like, hey, thanks, doc, that has helped me understand what to expect next. That's something I have felt me connected more to my patients. And I hope that'll help other clinicians as well to connect with their patients in these tough times for their families too.
Thank you. I thought that was all really helpful, and just appreciate the perspective and sharing some of how you connect with patients. And really that element of like, don't expect this to get solved right away, right? This isn't a magic pill situation. That was really helpful. What is like one thing you want folks to take away from this conversation about BPSD, either recognizing it, managing it, learning more about it?
I think I would highlight that this is not an easy problem, right? I want to reflect that this is a complex problem. And as clinicians, if we ever stumble across it, and if you're thinking about it, know that this is a complex problem you're up against. If you're not so sure, don't hesitate to ask another colleague around you, brainstorm, or look for some guidance or help is completely okay. These are challenging situations. You're not alone in this journey. But at the same time, there is literature, there are resources. Geriatricians are a wonderful resource to connect as they do have experience for caring for older adults with dementia. There are geriatric psychiatrists who are available, like who can help with some of the advanced behaviors if you're struggling with or if you're not noticing some good response with early managements that you have deployed. So there are resources, there are additional help, there are wonderful resources online, there are resources, scientific publications coming out on these topics constantly. So know your resources in your community. Don't be alone in this journey. Don't let this demoralize you.
That's wonderful. Thank you so much. Thank you for sharing. And I hope people watch the webinar where we get to go into a little more detail on some of the background and the data and the instruments. I think it's all just so helpful because this topic is never going to get old. And glad to hear too that we're having some therapeutic and treatment option advancements. So thank you so much. Thank you, Dr. Pagali.
Thank you so much, Dr. Chodos. Thanks for the opportunity to talk to you today.
Thank you for listening in to our wonderful guests. And thank you to Lisa Costello, our audio editor and voice specialist. We want to make sure you know you can get CE and CME credits by filling out the evaluation survey located in the podcast description. This is all possible through support from West Health and the hard work of our Dementia Care Aware team. If you want to learn more about our program, please visit our website, dementiacareaware.org.